Okay, we are live. Let's get started. Welcome everyone for joining our webinar. Thank you very much. And we have an amazing guest speaker today at our webinar. We have Dr. Jeffrey Rosenthal. Hi, Dr. Rosenthal.
Hi, great to be here. Thank you. Look forward to this. We're all
Yes, so we have a lot of interesting information that we will be sharing. So we will cover a synergy of multiple treatment modalities for beautiful results for enhancing facial features. Type of patient that would be selected, that would be appropriate for this treatment sequences, advances technique for this treatment, real case studies that we'll be discussing that was submitted to us generally from some of our patients and from Dr. Rosenthal as well, and some before and after presentation. So a lot of information. Stay tuned, and I hope you would learn something new from today's webinar. So, for those of you who stay till the end, we have some exciting gifts that we'll be sharing with us. So, stay tuned, and you will definitely have a question and answer section. You could submit your questions during the presentation. If they're appropriate, we will answer them while we're presenting in the chat box, and at the same time, we will be answering them at the end of the presentation as well. Okay, and this is the contact person for our course coordinator, Valentina. If you have any questions in regards to our courses, this is the number that you could call after the webinar. This is some of the QR codes to our social media and the website. We have Dr. Rosenthal's Instagram and a website code. And we also have for our training at TS Academy website and QR code for Instagram. Follow us. Share that information. There's a lot of wonderful information on Dr. Rosenthal's Instagram that he shares his knowledge. We do a lot of educational videos as well. So if you're not following us yet, please do so. I'm sure you would learn a lot of excellent and exciting things in respect to aesthetic medicine. So, before we start, we would like to know where our audience is from. Take a minute and write in the chat where you're from, what kind of license you have, do you have experience in aesthetics, so we kind of know who we're talking to. And while you do that, I will introduce our guest speaker. So, a little bit about Dr. Rosenthal, board certified plastic surgeon. He's also an international artist, so he has that artistic eye, and that's, I'm sure, how he assesses his patients and makes the beautiful work that you will see some before and afters down the slides. He is award-winning practice. You are in Connecticut, correct, Dr. Rosenthal?
in Fairfield, Connecticut.
Yes, he's in Fairfield, Connecticut, and former chief of the plastic surgery in the Bridgeport Hospital. As a media, he was featured on different television shows, and he was recognized for his innovative facial rejuvenation techniques, specialized in multiple plastic surgeries, different body parts, face including PDO thread lifting, for different parts. Endolift laser, I know it's your favorite topic as well. Maybe we'll do another webinar just for endolift. We will see. Advanced dermafiller technique, facial sculpting. I've seen Dr. Rosenthal work recently when we were doing training, and amazing skills, person that I observed, and I've been training for a long time, so I could see when someone has good hands or not. And Dr. Rosenthal has definitely impressed me with his skills on working with threads and cannulas. So thank you for that. I'm sure you will share some of that knowledge with us during presentation. And your philosophy is object of never rush and have your patients to do the best treatments. Tell us a little bit about that. Why is it so important to have that attitude? And I see your work, and it's amazing. You still keep the sterile technique. You still recap your needles and cannulas when you work, which I don't see a lot, unfortunately. But tell me where it's all coming from, and kind of let us know a little bit of why that particular way you practice, and if it's important for our audience to know the details as well.
Well, when you go through a residency of 12 years to be a plastic surgeon, you learn a lot of techniques, but it's really afterwards in my private practice that I've developed all of these procedures to refine them And I look at the face as a blank canvas where I'm going to sculpt it. But more importantly, I have to listen to each patient. I have to find out what bothers them so that I can adjust what I do. So listening is a very critical skill, as well as communication between the patient and myself. So my pact with each patient is you will tell me what you want to do. I will tell you what it's possible to do, and then we have to agree on it. And then the technique of doing these is critical. You have to have the artistic hands and eye of a surgeon and an artist, but you have to have the background as a scientist and a surgeon in order to make sure that things are optimal for the patient so that there's no complications. No one likes complications. I dislike them. We want everyone to be looking well and healing the best we can. And the only way to do that is to be precise, take your time, and never rush. I do one patient at a time, and my patients realize that I will not rush through them. And they look at me when we're finished with the procedure, and when I smile, they say, "Oh, good, now we're happy." And that's how I like to run my practice.
Thank you for that. We need more people like you in our field. So I'm glad to get to know you. And it was a pleasant experience for the time that we've been talking and discussing. I see your diligence to the field. A little bit about myself. I've been in education for over 15 years. So I'm a founder of Rebalance Beauty and Wellness Clinic in the city. We're on 59 on Madison. Right after COVID, during that time, I got accredited and offer and open up the training academy where we trained practitioners at different levels for a lot of aesthetic trainings. I've been presenting, writing articles, writing books for many years, so have a lot of knowledge to share, and I do it with pleasure. And I presented in a lot of international conferences as well. So was nominated Best Faculty of the Year in 2018, which makes me proud. For those of you who've been in my classes, and I see some familiar names who joined us, so thank you for supporting us with that. And you know how much I share to get my knowledge. And the reason why I started Academy, because I've seen different type of training, and it's painful to watch when people train and train wrong. And I'm sure Dr. Rosenthal, you agree with me. The most important thing for a clinician is if you know the right skill, you teach the right skill. And I feel, and maybe it's harsh to say that, if you don't know what you're doing, you better not to teach that. But unfortunately, that doesn't seem to be everybody's opinion. But I do take my teaching skills carefully and try to share my knowledge. And I urge you guys, if you ever go to any training, make sure that you get to the right people and see what kind of training they provide, because it's hard to retrain people new skills if they already have the skills that were not taught properly. Um, Unfortunately, taught the wrong way, and it's very hard to retrain. I do retrain some people, but it's not easy usually. So, we're saying all of that. Now let's see who is our audience.
Before we go on, I should say that you're a wonderful teacher and that your facility is pristine and is beautiful. And anyone who has a procedure there or comes from one of the teaching sessions will find that it's done very professionally.
Thank you. Thank you. I appreciate the comment. Okay, so we have people joining us from New York and out of state. I have Oklahoma. I see Texas, I see California, and if we have a mix of medical doctors, we have RNs, we have nurse practitioners. I see that we have physician assistants, and oh, I see Alaska. Okay, I actually had a student a few years back that traveled all the way from Alaska to train with us. So yeah, I see a lot of different professions. I guess it is a popular field nowadays, and during our training courses, I do see a wide variety of medical professional joining us, which is interesting. And everybody has their own view of seeing aesthetics and have their own scope of practice. But before treating any patient, I think, and that brings us to our slide that we have right now. And Dr. Rosenthal, I would like you to share a little bit of your experience. Before we do any procedures or offer any procedures to the patient, we need to do a proper assessment. So what is proper assessment in your experience? What do we look at when we assess our patient before offering our aesthetic procedures? What is the most important, I guess, aspect of doing proper assessment?
Well, first of all, we have to treat any procedure as a medical procedure, which requires getting a very excellent and complete history and physical. If they're on medications that will affect bleeding, if they have immune problems, if they have psoriasis, if they have breakdown in their skin, or any other complication of heart or lung, we have to understand that because we are using epinephrine, which could increase the heart rate. We're putting fillers or threads in an individual where if they have an immune response, it can attack that. They can get lumps and nodules, not from the product, but from the body's immune response. So taking a complete history and physical is important. And then we have to then evaluate the patient's face or what they've come in for very carefully. And what often we don't do is we jump to, let's just throw some filler in here or there. But you have to understand that the face is asymmetrical. We're not born symmetrically. Our bones grow not from the center out, but we fuse in the middle. And because of that, one orbit is higher or lower, one cheek is higher or lower, and the side that's lower, you'll have a lower jowl and probably a lower eyebrow. And so all of these things are important, as well as identifying if you're doing any neurotoxin, if there's a degree of ptosis. And why is that important? Because if you're putting a neurotoxin in the forehead and you're diminishing the excursion or range of the eyebrow, and the eyebrow is an accessory elevator of the lid, well, you've diminished that lid's ability to come up if they have ptosis. So understanding asymmetry, understanding balance, not symmetry. You don't want to get the person even. In fact, they did that for presidents. They took both right sides of the face, they put them together. It didn't look like the person at all. So the subtle asymmetries of our face make us unique and beautiful. Those are the things that you have to identify in order to correct the imbalances of the face. So looking at the shape of the lips, where the nose is, the cheek projection, where the projection is on the cheek. Often the mistake is to make the cheek projection in the very front of the cheek. Well, it isn't there. It's sort of lateral to that position. So we have to look at bone loss, tissue loss, and we'll get into aging. But all these come into play when you're evaluating someone. And then, as I said, communication is crucial to find out actually why the patient is there, not why you're there to treat them and what you want to do, but what do they want to get out of this? You can have the best result, but if it's not what the patient requested or wanted, you failed. So there has to be a joint understanding and a joint communication, and that will give you optimal results.
So you need to understand what they have in mind, what's beautiful for them, not what's beautiful for you, which seems to be a common mistake on the clinicians and medical practitioner side that join aesthetics, right? You need to, I usually teach my students, you need to be a little bit of a psychologist and understand what's in their brain and see what they feel suits them, not what you see as a clinician, correct?
Yes, and what's important is you've just used the word beautiful. I never tell a patient I'm going to make them beautiful because beauty comes from within. If you're a kind, considerate, nice person from within, I can make you more attractive and truly beautiful on the outside if you're beautiful on the inside. I can make you more attractive if you're not beautiful on the inside, but I prefer the combination of both.
That's true. It's very much true. Okay. Before when we do assessment, we need to look at morphological changes due to aging, right? And aging, there's multiple changes that happen with skin elasticity, with bone loss, and with osteoporosis that's happening. Tell us a little bit more if that's something that you consider when you treat your patients, and how does that affect what type of treatment you offer to a patient if they come from different age group and they already have a bone loss or they just starting to develop a bone loss. So tell us a little bit if assessment part would be different based on what kind of facial structure patient comes in with, the age group and everything else.
Yes, so the facial bone structure is crucial, just like a house has support structure as well. Your bones support the tissues that are overlying it. The skin itself is made up of a protein collagen. And as we know, at between 25 and 30 onward, we lose between 1 and 1.5% collagen per year. So if you're looking at between 30 and 50, that's 20% or 30% of collagen loss in the skin. That's a huge amount of elastic tissue that's lost. of collagen that's going to hold up the skin itself. It becomes thinner, it becomes less elastic, and starts to fall. When we treat the face, we have to look at it as an onion. We have many layers to the face, and we just can't say, let's treat the skin and have a good result. We have to treat from the bone outward. So we have the bone, and then we have a fatty layer over the bone that allows the muscles to glide. On top of that, we have the muscle, and then we have another layer of fat that's going to give structure to the skin. And then we have the skin. And so when we go about treating a face for rejuvenation or anti-aging, we have to address all layers of the face and neck in order to get optimal results. The skeleton of the face, as it ages, we lose bone mass in the jaw, we lose bone mass in the maxillary area, in the corners of the jaw. And people say, well, my nose gets bigger and it droops. Well, it really doesn't get bigger and droop. What happens is the maxillary area starts to recede. And because of that, there's no support for the nose and it comes down. Just like the fat bulging around the eye. Why do we get that? We have a finite amount of fat around the eye. There's actually 5 compartments, and they're held back by a fascia that's sort of like a trampoline. And as we get bone loss along the orbits in the superior medial and inferior lateral direction, those structures that are supporting, holding back that fat no longer have the support. And so the fat now bulges. And that's when you go for a blepharoplasty. So the combination of loss of deeper fat, superficial fat, bone structure, and women start out with less bone mass. And because of that, they have more bone mass as they age. And so typically the lateral third of the mandible is receding, the chin recedes, the maxillary area gets smaller, and the lip, upper lip, then looks proportionally longer. The malar area starts to shrink as well, and the support of the skin with loss of deeper and superficial fat and no bone, the skin starts to sag in a inferior and medial direction. Now, the fat compartments are interesting. They all wither away except for 2, and that's the nasolabial fold area and the jowl area. The 2 that you don't want, those are the 2 that get bigger. And they start to fall medially and inferiorly. And so when you see a deep nasolabial fold, and we'll get into this later, you have to understand, why are you getting this? Well, you're getting it because the medial and central cheek fat compartment's no longer there, and the bone structure is gone. So the tissues are coming down. So you don't treat the nasolabial fold first, but you re-support the cheek in an upward direction. Once you support that, invariably you have much less to do in the nasolabial fold, as well as the tear trough area, which is under the eye. I really don't like treating that because it's been shown that filler can get into the fat compartments, or they can stay in those areas for a very long time and cause lumps and bumps, which are very difficult to remove. So an optimal way would be to resurface the skin, make it texturally better, and then lift up the cheek area, support the mandible, support the arch. And if you do all of these things properly with fillers, threads, or all the other modalities we use, then the face looks much better.
Right, and I agree with you. That's something that I also discuss in training. When people see deep nasolabial fold, first reaction is, okay, let's fill it in. No, you have to assess, is it the fold itself or is it the skin tissue that's creating the fold? And you just said it. I feel like we went to the same school together, which we did not, but at least we probably have been trained by people who have the same frame of thought. It's repositioning the tissue, lifting the skin that's creating the nasolabial fold, and obviously adding a little bit of volume. And we will discuss, I know you have a technique when we inject radis and other fillers on the bone to support the bone loss that was there. So we're looking at the whole face as a canvas. We're not treating particular face parts separately. And I'm not a big believer in under eye filler either, because it does cause a lot of swelling. It might worsen the condition of the fat bed that's hanging in there. So I also feel like if we give support and structure to the upper cheekbone and add volume and reposition, that will diminish the look of the under and kind of basically you don't need to put an under eye filler because you just gave enough support, and the look for under eyes hollowness got much better. So definitely on the same page with you on that topic. And this is signs of aging for the muscles that also happen, which could be treated with neuromodulators, and we will discuss it a little bit later. When we use combined treatments, we could get the best results. And this is one of the amazing before and afters that was submitted to us by Dr. Rosenthal. Tell us a little bit more how combining multiple modalities helped you to achieve beautiful results. And I could see here that definitely nasolabial folds were not filled in. It was repositioning of the tissues that gave such a beautiful result. But I will let you speak on that particular image that we have right now.
This is a perfect example of why you don't just jump in and do the first thing you see and fill the nasolabial folds and think you're going to get a great result. And so often, what I will do is, after an appropriate evaluation and speaking to the patient, I'll have a plan of a multimodality approach. And in this patient, I was using PDO, polydioxanone threads, which are polydioxanone. That's actually a synthetic material made out of something similar to a suture that I've been using for many, many years. It's very resistant to infection, and it stays around for around 6 months. It's degraded by the body. It's absorbed easily and released in water and carbon dioxide. And it's a synthetic material, but what it does, it causes a minor inflammatory response where it causes the macrophages to come in the area that stimulate the fibroblasts, and the fibroblasts, which are going to make your collagen, are then stimulated to work. And so it's a micro-inflammatory process. But on the other hand, what it's doing is it's repositioning loose tissues. And we'll get into threads later, but they have projections on them or cogs that are in the deeper tissue and will lift up. So in this individual, you can see that her cheek malar mounds are coming inferiorly and medially, and that's what's contributing to the deep nasolabial folds. And also she has some jowling and some labial mental area depressions as well. And so you want to fill and contour all of these areas. So the first thing I went about doing was putting some radius, which is a calcium-based product, along the mandible and along the arch in order to give structural support. Then I was able to apply some threads through little tiny pinstick holes to resupport the cheek and the mandible and the neck area. And you can see that the neck area is much cleaner and the bands are being pulled in a nice direction, and that the face is not being distorted. Look at the corners of the mouth, though, as if you want to see distortion of either threads or even a facelift. If they're deformed or being pulled up, that's signs of very poor procedure. So she's had these being pulled up. What I did not do is I didn't put hyaluronic acid in the superficial layer of the cheek. That's where the threads go. But in the labiomental depressions, I put some there to support the lip and to support the cheek in that region. So I can specifically isolate areas where I want to put specific fillers, and they have to lift or support the way I want them, and they have to be out of the range of where the threads will be. Otherwise, the threads won't work well. And so this is balancing again, repositioning, balancing, and revolumizing, not necessarily filling, but putting the volume back in the face where we've lost it, which is when you think of a facelift, and why does a plastic surgeon like threads and fillers? Well, when you think of a facelift, it's really just pulling and repositioning tissues. You can put some fat in the face, but it doesn't always take. You may get 30 to 50% of the fat. And it also doesn't come out of the syringe as smoothly as the fillers that we now use. So with the combination of threads, certain fillers, neurotoxins, and an endolift laser that I have that goes under the skin, I can tighten, soften the bulging fat with the endolift laser. I can reposition tissues and then appropriately rebalance the face. And that's the multimodality approach with what we're doing.
Yes, amazing results. We have a first question. One question, first question is actually from me. I know we discussed it before, but I don't know if that patient had platysmal band treated or not, because I'm looking at her neck. It looks much better, but I don't know, because I know that's one of your techniques that you use. Did we treat platysmal band for this patient or no?
In this patient, I didn't because
No.
they
Okay.
were not significant. I was able also, I do like to treat the bands a week or two before because it weakens the anterior medial edge of the platysmal muscle. And if you can weaken that when you're pulling back with the threads or repositioning them, they will move better. And this patient, you're just seeing her before, and then the after is basically 10 minutes later. It's
Mhm.
very soon after. This was a teaching seminar that I was
Mhm.
giving, and I was showing procedures that I was using.
So that's the second question is, do you do these procedures on the same day? You already mentioned that if you're doing toxins for platysmal bands, you do them a week or two before for, I'm assuming, for toxin to work. How about fillers, threads? Can they be done on the same day? I'm assuming because it's different layers, they can, but you tell us if you do them on the same day.
Sure. It depends upon which filler you're using, a hyaluronic acid versus radius. Radius, again, is calcium, it's a structural. So if I put it along the malar arch, the malar, or along the jaw, it will be out of the realm or out of the way of the thread. So that's easily done. If I'm going to fill some nasolabial fold and the threads never go into that area because you would deform the face, then I could also put some hyaluronic acid in that area, which I did not do in this case. So I can do multiple procedures at the same time. If I'm doing my endolift laser, I frequently will add threads to it because you're getting thermal relaxation after the first day or two. Even though I've liquefied fat along the nasolabial fold and the jawline, the skin will relax. And so to prevent that and to maintain it in an upward backward position, I will put some threads in there as well. Aren't many people in the country or the world that do that, but my results seem to speak for themselves when I do that. So yes, you have to choose which other procedure goes in combination, and you have to have a good idea of what you're doing and that they don't interfere with each other, but they actually complement one another. That's the key, complement.
Mhm. No, excellent. And I feel like you do get, I like the multi modality approach because you're addressing several problems. And for most of our patients, they don't come just with one problem. They come with multiple problems. And if we're addressing just one, I feel like we miss the rest of it and we're not getting the results that we want because we are not addressing the whole face as a canvas. And things that this multimodality approach could achieve is correcting lines and wrinkles, facial balancing and volume restoration, everything that we discussed before, and giving for natural look, which it's getting more and more trendy right now that people looking for natural look as compared to plastic look that was there popular before. So let's start going into more detail. Let's start with the tread lifting because that's one of the modalities that we use. So with tread lifting, it's a unique, and you kind of briefly touched on this as already, helps to build collagen, helps to reposition the tissue, and help us to return back a little bit the volume, especially when we use a combination. So tell us a little bit more on different tread lifting procedures that you've done. What look, who is the right candidate, I guess? Why would you choose on someone to do the tread lift versus how would you know if you need to replace the volume? Like, how do you choose like which patient would need all three modalities or just need one, or you start somewhere? Kind of tell us a little bit more from that perspective. What are your thoughts and what is your experience in that area?
Well, we have to first start from the outer part of the face, the skin, and we have to see how vibrant it is. And we now have peptides and exosomes and other stem cells and mesotherapy procedures that we can pulse into the skin and improve the quality of the skin itself. I actually have my patients start on a collagen supplement powder that increases collagen as well. It's not collagen, but it does increase the collagen vibrancy. So you have to evaluate the skin. If you have someone with a very thin parchment skin without a lot of subcutaneous fat, then threads are not ideal. You can still use them, but you have to be very cautious how you're placing them and what the vectors are and the positioning. So the skin, the underlying fat, where is the fat? Where is the malar fat mound? Has it descended? Is it withered away? Is there anything there? What do the jowls look like? What's the nasolabial fold? Is there fat? And so all these come into play in choosing a patient that will be optimal for threads. Patients that are not optimal for threads are someone that has a very, very heavy, big neck with hanging skin, hanging platysmal bands, and a lot of fat. You would have to do some liposuction on them first, bring them back, or do endolift laser to take some of the fat away, and then at a later date, put some threads in. So that would be a patient that I would say would not be optimal. And so there's optimal patients, there's patients that are moderately good, and there's patients that will not get a great result. However, I've had those patients come to me and say, my daughter or son's getting married in 6 or 8 weeks. I don't have time for a facelift. I'd be happy if you just tighten my jawline a little bit, give me a little bit better neck, and lift me up. And they're thrilled with it. So identification of the problems of the structure, the underlying structure, the skin quality, and what the patient really wants. Now you have to remember this is a office procedure done under local anesthetic. It is minimally uncomfortable. The only time you get discomfort is when you're going through the scar tissue under the skin. In those patients that have terrible sun damage, when you're passing a blunt cannula, I tell them you may feel an ouch for a moment or two, 1 second, and then it's done because there is local anesthetic in there. So choosing a patient that understands what you're going to do helps a lot. If they think you're going to get a facelift from this, they don't, but they will get great results. And in fact, a combination of threads, fillers, neurotoxins, I probably can get as good or even better result. The other thing that's beneficial of the threads is that they're put through little tiny pinstick holes that close within 24 to 48 hours. There's no big open scars. The risk of infection is minimal. And so bleeding is also minimal because you're using a blunt cannula to pass these threads. Now, we do have threads with sharper needles, which I do not recommend for novices. They're very sophisticated and can be dangerous. But having said that, threads can be dangerous in the hands of someone who doesn't know what they're doing. And that's where repeated teaching, repeated going with hands-on seminars where you're learning from someone who shows you angles, vectors, the depth. The depth is crucial. Remember, underneath, if you go too deep, you can go into the fibrous tissue or SMAS overhanging the neurological structures. If you get into that, you can cause facial damage. There's all kinds of big vessels in the neck. If you go too deep under the platysmal muscle, you can get into the big vessels, you can get into the arteries. And so the angle, the type of thread, the amount of threads, I will often put between 25 and 30 threads in a face and in different angles going from the top to the bottom and then from the cheek going into the temple. All of these things have to be carefully evaluated. And if you do so, the results are very, very appealing to the patient. And that's why I appreciate it so much.
Yes, one of the questions is being asked, and I actually offer it to my patients, but I would like to know your opinion. For someone that comes in and have a lot of skin laxity, might not be a great candidate yet for threads. What are your thoughts on treating them for a few times with biostimulators such as Sculptra and help them to build collagen and come back for thread lifting, or offer them a mono threads first to kind of build the structure a little bit and then come back for the lifting threads? Have you tried it, and what is your experience on results if that's the treatment modality that we choose? Like pre-treating them basically before placing the threads. Preparing.
I like to pre-treat the patients with mesotherapy procedure that actually pulses through different peptides and PDRN and other products that will stimulate the collagen production. That I believe is very, very helpful. One of the procedures is what the women who get their Oscars, they go for these treatments, and afterwards you do have a glow, but the main bent of it is to stimulate collagen.
Mhm.
A dilute radius I've been doing for about 15, 20 years, actually, to spread it under the skin itself in a very dilute manner. And it's as good as sculpture in stimulating collagen formation. Sculpture is also very good in the area, but when you mix it up and when you inject it, you have to make sure it's well mixed because you can get lumps or bumps deep down, and you can even get nodules in the actual muscle of the neck itself. I've seen that. Actually, in a course that I was in Boston 2 days ago, we were discussing nodules and problems from filler, sculpture, and other products that are either injected incorrectly or the body just accumulated them in the wrong areas. But yes, I believe in those individuals that have very, very poor collagen in their skin, very thin. They would benefit from other procedures before. But the vast majority of patients that I do I can do immediately and then continue to give them skin treatments as well.
Mhm. You just mentioned that you've been at a training 2 days ago. I thought you know everything, Dr. Rosenthal. You still train? You
I have a lifelong training. I love to learn.
I know.
I'm always learning from someone. There's always so much to learn. That's how you become good, and you don't just sit back and say, I know everything. The ones that know everything get into a lot of trouble. Uh,
Yes, that's
just to
true.
know enough and to realize you don't know as much as you'd like to learn. I review textbooks for the whole country in plastic surgery, and I don't get paid for that. Why do I do it? Because I read things from around the world that are published, and I'm always learning from someone and going to meetings and speaking to individuals such as yourself and learning a lot.
Yes, me too. I'm constantly learning. I'm a perpetual student for the rest of my life, I guess. But we have to. If you're in this field, there's always something new comes up, either new technique, a new modality, new treatment, new product. And if you're not on top of the new modalities with social media, patients are seeing this promotions and would like to try those treatments. And if you don't know what they're asking, they will go to another provider that might not be as skilled as you. And I had patients that come back, they've tried something somewhere else, and then they come back for me to fix it. It's usually disheartening to see it, but yes, being constantly on the edge and seeing new things and learning new things, I'm on the same mind. So smooth thread versus barbed threads, different modality, different treatment areas, different indications, and you already mentioned that proper placement is the key based on which problem we're assessing, which area we're addressing, and what are we doing with the smooth threads or cock threads. It's also different and it's specific to the patient, specific to the result that we're looking for. An objective of thread lifting is to build the collagen, to support the tissue, to reposition the tissue, but it's not to replace a plastic surgery, correct? So people have a lot of misunderstanding and downside for the tread lifting or misunderstanding, I should say, for the tread lifting come up when they advertising as a lunchtime facelift, and that's not the case. So you as a plastic surgeon that have done both, what is your take on tread lifting? Who is the right candidate? Who is not? And should it be advertised as a replacement for plastic surgery, or it's something that should be done for the right patient, for the right candidate?
Well, selection is the key and finding out why they want something done. Now, you have to understand when we do threads or fillers, these are things that have to be repeated every 1 to 2 years. However, the downtime is minimal, a few days, and you can't do real vigorous sports for maybe a week. When you do a facelift, the downtime is significant. The scars are much longer and significant. There is a surgical center or a hospital where you have to be put to sleep, or if it's even done under IV sedation. There are potential major risks versus threads, very minimal downtime, and also discomfort wise, almost nothing. In terms of the lunchtime thread lift, I never was able to understand how they can do that unless you're doing minimal threads or doing two threads. If you're putting two threads in, you can do it a coffee break then instead of a lunchtime. But if you're doing two threads, you don't know what you're doing. And so, listen, if you're 35 years old, you want a little cheap pop, you put a few threads in there, okay. And they probably don't even need it. But when you're getting into the 40s, 50s, 60s, And I've even done 70s and 80-year-olds. I have one 93-year-old who's still a singer. She was singing with Sinatra and Marilyn Monroe, and every 6 months she'll come up and I'll do a procedure on her in my office. So it is never, they're never fast. You have to evaluate the patient. You have to cleanse the face. That alone, taking off makeup. Patients cannot come in with makeup because you're putting things through dirty makeup. That's wrong. And so you have to take off any makeup that they come with because they don't always want to walk around without the makeup. You have to draw on the face. When I do fillers, I draw a topographical map on the area where I want to place it. During the procedure, I will put some filler in. I will mold it with my hands. I'll have them sit up. I'll see if that took place the way I want it to, lie down, and I'll do it again. I do the same procedure with threads. So when you're talking about a lunchtime procedure, it's really not true for threads. Can you do fillers within 45 minutes to an hour? Yes, but you have to take your time, and it shouldn't be on a clock. Shouldn't say, well, I have 30 minutes and I have to get back to lunch. No, it's you come in, I'm going to spend as much time as necessary to correct the imbalance and make you look rejuvenated and natural. You don't want someone to look like they've been pulled or have had a procedure. You want them to look naturally refreshed. The only way to do that is to take your time to properly evaluate the face as it's an art project. You're sculpting, you're designing, you're using your hands and your mind and your eye to evaluate and then say, this is what has to be done. And so that's my philosophy.
That's another before and after beautiful results. So tell us a little bit of what you've done for this beautiful patient. And
Well, this patient is actually in her mid 40s, but she's thin. And so, because she's thin, she has, you can see in the malar area, depressions, and she does not have any fat in that region. She's starting some jowl fatting and some bulging in the lower face. Her jawline is still very nice, and her neck, she's starting to get some banding, and her skin quality is from sun damage. She needs some rejuvenation of that as well. And so we've put some neurotoxin in her neck a little bit. I believe I put some in the jawline as well. And then I brought her back and I did some radius or deep filler to the malar area. And then using different hyaluronic acids that I have access to, I put it in the malar region with a blunt cannula, going in different directions and different vectors to sculpt and contour it. And we've put some along the jawline as well.
so it's not a work of one treatment, they come in and they're done. It's multiple approaches, multiple times. And that's something that I feel needs to be discussed with the patient when they come in. They need to realize that it's not a quick fix. It's actually a whole program, different modalities together to get to the results that they're looking for.
And in this particular patient, I did the hyaluronic acid as a secondary procedure because after the putting the radius deep down, I did put some threads in her face. She didn't need the 25 or 30 threads that I would do in someone who has more of a hanging face. But we did a number of threads to lift and reposition the face, and there was nothing put in the nasolabial folds. These were just repositioned as well as the jawline. The jawline is lovely. And what is great about this is that she could walk around the street, no one would know anything was done. She looks so well and natural. She just looks rejuvenated. That's the key at every age to look well,
And refreshed.
refreshed.
And this is some other before and afters as well. This is one of our patients, actually. We did pediotrads and we did some contouring for the jaw, and you could see that the jowling is lifted. So pretty a good result. And we also did some PRP procedures for the patient for the skin texture. So it was a multimodality approach to get to the result that patient is looking for, and was explained. So patients usually once they know what to expect, obviously you will see better results and better understanding. Now let's discuss volume loss due to aging and filler placement. If we've done already pediotrads, then we could now, next modality would be to replace fat. So how do you approach this part? If you're offering fillers, I know you work a lot with cannulas, same like me, I love cannulas. So how do you know where to replace, where to place, when to place? Kind of give us a overview of volume loss, and how do we replace volume loss, and how do we make a decision who need volume replacement versus biostimulating agents and working with Radis on the bone? Like, how do we make that decision?
Well, volume replacement to me is working from the bone out. And so often I will put radius along the malar area and along the jaw to give that first initial structural push. But that doesn't replace the contour. So I look at radius as sort of a cake. And the cake, when you make a cake, it's not always smooth and even. And what you want to do is you want to put the icing on top. And that's where the hyaluronic acids come in. And using various cannulas, I can go into the malar area. The preauricular area often is sunken. You've lost a lot of tissue there, but it's also a very dangerous area to inject without really good technique and knowledge because that's where the parotid is. And if you go too deep, you will put filler into the parotid and you will have salivary problems, sialocele or lumps or bumps in the parotid itself. And so frequently in this area where women need, and some men, need fillers, there's not a lot of fat, but they have a big depression in front of the ear. Right in front of the ear, you also have two big arteries running up. And so you have to be very cognizant of where the arteries are and not to put the fillers in deeply. So you will put them in the malar area. The arch often needs some filler as well. You can palpate the bone arch. There's not a lot of fat over it, but you want to sculpt the face so it has a smooth undulating appearance from the forehead. Should be a slight depression in the temple area for a woman, a man, a slight bulge. And then it goes over the arch and it goes under the arch into a depression. And what you're looking at is reflection and capturing of light, which is really critical. So when an artist paints a painting, you'll notice that there's light projecting and darkness. And so projection off the malar and the arch is where you want to have a projection of light emanating, but you want that light captured underneath the arch itself. And that gives that nice contour, which then smoothly goes into the jawline. If you have big depressions in most of the areas, they have to be contoured and gently filled. And so you have to evaluate what you're trying to do, where you're going to place it, whether you're going to build up the jaw with radius and then put a little hyaluronic acid over that, or even build up the chin as well. You can do that. Again, the tear trough area, I'm not a fan of doing. In this individual, you can see that she has a sort of a bulge. She has a depression under the eye and then a bulge, and part of that bulge is malar. It's malar bags. And what is a malar bag? Well, it's a combination of loose orbicularis muscle that's hanging down, some fluid, and lymphatics. And there's a deep and a superficial lymphatic in that area. And if you fill that area with a filler, you will block the lymphatics and you will have obstruction for a very, very, very long time. So
Yes.
that when I mark the face, I deliberately mark this area around the malar bag and I'd never inject into that area. I can fill around it to soften it, but I don't inject that area. So you have to know where you're injecting and what you're injecting. And then lastly, if the nasolabial fold after I've lifted up the cheek and built up the jawline is still too deep, I will go with a cannula in that area vertically and then crisscrossing it in order to smooth it out. Now, you have to be very careful not to go too deep into the bone because that's where the angular artery off the facial nerve comes. And if you get into that, it will then feed into the eye region and you can get blindness. And so you don't want to do a deep needle injection in the nasolabial fold. The piriform fossa area, you can, and especially if you have an ultrasound where you can test where the blood vessels are. Often they're just a millimeter or two above the bone. So you have to be careful where you're doing that. If you start out lower near the cheek area, the vessel is more superficial, and that's where using a cannula in this area is much, much safer. The last thing you want to do is cause an occlusion of a vessel in the cheek or the lips themselves.
Yes, it's very important. And I have more questions coming in. So since they're on the topic, I we will answer them now instead of waiting until the end of the webinar. When do we know? When do we decide if we are administering sculpture or hyaluronic acid-based fillers or Radist, which is hyperdiluted. I will answer, and then you guys and you, Dr. Rosenthal, could continue. Hyaluronic acid-based fillers, they are volumizer. They're replacing the volume. And sculpture and Radist, especially Radist in hyperdiluted form, they're more for collagen building and stimulation. So they're not used interchangeably. It's totally two different modalities for different reasons, for different indications. So I've seen people administering sculpture on the bone. I've seen people administering sculpture to add volume. It adds volume a little bit and it kind of stimulates collagen production, but it's not a good product for volumization. I might be wrong, Dr. Rosenthal. What are your thoughts on that topic?
Well, sculpture is a product that you have to repeat often every 4 to 6 weeks. Uh,
Mhm.
and it was actually designed for AIDS patients that had no facial fat. And if
Mhm.
you're using it on a patient that has no facial fat, you can do anything with these people. And if you build it up every 4 to 6 or every 4 to 8 weeks, you're going to get an improvement. When you have someone with moderate fat loss, my patients don't want to wait 4 to 8 weeks to see something. They want something more instantaneously. So you can use a combination of sculpture with fillers. You can use a combination with threads in different settings. There's nothing wrong with that. It will increase the collagen formation in the skin. It does give nice results. Radius is probably as comparable as sculpture for collagen stimulation, and you also get the volumization or lifting of it. But if you don't need a fill and you just want some collagen stimulation, then sculpture is probably a nice product. I do have a friend in Florida who's pretty famous that insists on putting it along the bone, and he feels that it's also stimulating the bone collagen in that area. And as his patients age, they will age more gracefully. So he puts it along the bone. I think most patients and most people that are doing sculpture do not put it along the bone.
Right, and as I said, with radis, I could understand with radis, it has calcium kind of maybe help to build bone mass, but with sculpture, to be seen, I guess. And different new modalities, different new experiments, but I feel if you want if there's a lot of volume loss and you want to replace that volume, you would need to replace it with hyaluronic acid-based fillers. If you want collagen stimulation, then it's sculpture and radis that's hyperdiluted. Not hyperdiluted radis could be used as a volumizer as well, but I don't think you could replace if there's significant volume loss. With sculpture, you can't replace that volume loss. It depends, I guess, also on how much volume we would like to add. So it's totally different modalities and they're not interchangeable. We could use combine, and I do a lot too to get the best results. And this is other before and afters for this is the same one. How about this model, Dr. Rosenthal?
This is a very
What have you
interesting
done?
woman. She's from the South, and she wanted a little better jawline. She was starting to get some jowls, and so on this, I was using a different type of thread called Silhouette Instalift. It's a um, cones with needles attached to them, and it's if you're not very good at using the needles. You can, it's very dangerous. So I was putting them in the jaw. And then on the other side, on the left side of her face, which is sort of facing away from you, she had hollows in that labiomental sulcus area. And I was filling that with hyaluronic acids. And then I put a little bit in the commissures as well to give her a nice balance. I may have put a little bit in her chin on the left side, which, as you can see, is a little off as well. So you're seeing this just 10 minutes after I did her.
Beautiful results. So no bruising, no downtime, which is pretty good. And we already discussed this patient. This is one of our patients. She is a 62-year-old female, also multimodality. She had toxins down in her forehead. We use Radis as a volumizer for her on the bone, and plus we did hyperdiluted Radis and under the skin, some lip fillers, perioral lines. So we did Radis for her neck. She did tread lifts on the sides of her cheeks as well. So this is a few months treatment, plus we did PRP for her skin. And She looks very natural. She looks natural. She looks 10, 15 years younger and fresher. We didn't change her facial structure. We didn't change much on her bone structure. Like we didn't change her appearance. We just refreshed it and made her look better. So that's kind of the work that we're looking for and the look that we're trying to achieve for the patients, providing refreshment. And this is a patient that never done anything before. She came in, she was already, I believe, 61, 62, if I'm not wrong, when she came to us. And that's what we were able to do for her. She was very happy. She actually got married after this and kind of left us. But that's what to strive for, right? Dr. Rosenthal tell us.
I think this is showing ideal results for the individual. And what's really nice also is that the lips aren't pouting and overly big. And, I personally use a cannula for 80% of filling the lips. Why do I do that? Because you have to understand that the labial artery runs between the wet and dry mucosa, below the muscle in most of them, but in a percentage it's in the muscle, and in a percentage it's above the muscle. And so if you're using a sharp needle and you're doing most of the lip in the vertical from north to south, and you're going into the wet mucosa, there's a very, very good chance that you're going to cause occlusion of that labial artery. Same thing with the lower lip. You have to be very careful how you're doing that. So I would use a cannula for filling 80, 90%. And then in the filter area or in the mid portion of the lip or in the two lobules in the lower, I would then selectively use a needle, but again, not going from the outer all the way down, but I'll use oblique angles or horizontal angles and always stay away from where I believe the arteries are, because to have a lip occlusion is a very, very unhappy event for both the patient and who's ever injecting. Fortunately,
Yes,
it will
that's
happen.
for sure.
And understanding anatomy and technique, and going back to all of this, it's training. You have to train and train. And why do I go to meetings? Because I watch people do things. I learn the good and I learn the bad. And I'm always learning and trying to better myself. And that's where your facility comes in. You can't just do these things once and say, I'm good at it. It's even if you've been doing threads for years, and I train threaders that come and they do them, and when they start doing them, I say, you know what? Let's do it my way this time, and you can go back and do it your own. But it's constantly learning and upgrading techniques,
Yes,
and it's
that's for sure.
hands-on that's important. You can't get it from watching a webinar. You can get an understanding of what it should look like, but you have to really be able to evaluate, touch the skin, and use the threads or the fillers.
So you can learn things by watching Dr. YouTube, Dr. Instagram, now Dr. ChatGPT, right? It's soon it's going to be Professor ChatGPT. So you can't master and become a good injector just by watching people, or you can.
I don't think you can be a great threader or injector just by watching these. But
Try.
if you've gone for courses, repeated courses, and then you continually upgrade your information flow by watching other webinars and watching and learning and reading, then yes. But you have to have a good core. You have to have the basic understanding of anatomy, technology, technique, threads, what all these products are going to do and how you're going to use them. And then you can always embellish upon your fund of knowledge, of course.
Yes, that's for sure. One of the questions that came in, what would you recommend for under eye hollowness? Well, for this patient, actually, we didn't treat her under eyes. We just supported her zygomatic arch. We injected and we supported, and you could see just by changing that portion, just adding volume and supporting her zygomatic arch and around the orbital rim, her dark circles and under eye hollowness is almost gone. I mean, obviously she needs more work for under eye wrinkles, and she's received a few more sessions of PRP and PRF under the eyes, which I don't have that picture. But people have a common misunderstanding that when someone has hollow eyes like her, you need to do the tear trough, and that's not the case. First, you need to support and build around the orbital rim, support the zygomatic arch, support the cheekbones, and then, if needed, do under eyes. And you tell me, Dr. Rosenthal, if you think it's different. But
No,
that's
no, I
my
agree 100% with you, as I've alluded to before. Treating tear troughs initially, I think, is in my concept of face a very poor way to go about it. Can you, if you've done everything in the world and you have a little bit, then you can put it below the bone, but you have to be very, very careful how much you're using and not get it into the fat pads of the eye itself because that can be very prolonged. It could last years. You could have lumps there for many, many years. And so, any area of excessive motion that you're putting filler in, it can go into the muscle, it can move. And so, you don't want that to occur or get into the fat pad. So, I agree. What you did on this woman is very remarkable. Good, excellent results.
Thank you. So, neurotoxins, right? A big part of facial rejuvenation. And in regards, if we're using combined modalities, tell us a little bit more how using neurotoxin in the neck and in the lower jaw could help with results of the threadlets, because people don't look at these modalities together. They look at it mostly separately, but I know when combined together, they support each other. So tell us a little bit more.
Well, let's start from the brow up. And what the object is when I do neurotoxins is not to make it so there's no wrinkling or lines there. And so I do micro injections in the forehead, the upper, and what that's doing is shrinking down some of the oil glands. I drew a map on the forehead areas I do not want to inject. I will inject into orbicularis in the lower brow so it releases it a little bit. My injection in the corrugators is never going downward but horizontally, and it's in the skin where it attaches. And even the lateral orbicularis, the technique is very different. Instead of doing punk little injections, I do a different technique. Working down the face, you can get the depressor anguli oris, the DAO, in the corner of the mouth that pulls the commissure down. You can inject into that area small amounts of toxin, but you have to be very careful because on the other side of that is the depressor, another depressor, labial inferior, and it's a hair breadth away. And if you get into that, then the lip won't come down well. It'll look flat and won't look well at all. You can inject along the jawline. And why do you do that? Because the platysmal muscle, which are two muscles that cross the jaw, go down to the clavicle, you sort of release them being pulled down, and it makes the angle below the jawline much nicer. You can put it in the chin itself where you have the peau d'orange or the little puckering. You can put some in there as well to improve it. But some of the best results that I see are when I put little blebs in the neck itself, almost like TB injections, and that will shrink down some of the oil glands and make the skin look much nicer and smoother. And I also will, with that, concomitantly put it in these neck bands. You can see on when you're facing the screen on the right, those little dots on the platysmal muscle. Those are the medial bands that are coming apart as we age. They come apart and down. And between that, if you have fat, there's usually fat. In this individual, there isn't. So by repeated injections of these bands spaced 4 months apart, you will not only shrink the muscle down, but if you're using threads or other modalities, you can actually move them a little bit. And you're also seeing lateral bands as well. So I have them grimace, and I can grab between my finger these bands and selectively inject them. So it can be put many areas of the face as long as you're not paralyzing areas. Some individuals even like it in the white roll, which they call a lip flip. I'm not a huge fan of it, but I've done it in individuals that request it. If you know what you're doing and you're putting very small amounts in, it's safe. So again, you have to know where you're putting this. Some of the lines that come down on the lateral where the orbicularis is, when you have creases there, and you try to chase these creases, well, some of those creases are from the zygomatic major muscle pulling up. And if you try to chase those creases and you inject them, you're going to paralyze that muscle. You're not going to get a good lift of your lip anymore. So you have to, again, understand anatomy clearly, understand technique, and understand how the products work in the dilutions. We use different dilutions for different areas of the face. So you have to understand that as well.
Yes, one of the questions actually, what dilution do you use for the neck and for the other part? I prefer to use one-to-one dilution. It gives me opportunity to target my injection because diffusion point is much smaller, and I use it for a different part of the face. I just need to know. It doesn't matter what dilution you use. I shouldn't say it doesn't matter, but you need to know the diffusion point of different dilutions. So if you happen to work with a smaller dilution, like one to one, then your injection points would be much closer because the diffusion point is much less. If you happen to have dilution of 1 to 2 or 2.5, then you need to spread out your injection points because the diffusion for that particular dilution would be much wider spread. So you don't overlap, or at least you have an idea of where those injections should be. I don't know if you have any other advice, Dr. Rosenthal, in regards to dilution. I work with different ones depending on what area I'm covering, but there seems to be a lot of confusion. I get these questions a lot from my patients. What is the right dilution? There's no right or wrong. You need to know which dilution you're using and how to use it. Tell us if you have any different
Well,
opinion on that.
I agree. You have to know the diffusion point, and it can be 1 centimeter from your injection, and it depends what you're doing. So, if I'm doing a whole neck for the skin itself, I actually want it to spread a little bit. So, my
Right.
my concentration may be 1 to 3 or 1 to 3.2. If I'm
Mhm.
putting it in the upper forehead, where I'm using micro injections and I'm putting 20 little injections, again, it may be 1 to 2.5, 1 to 3. I usually don't go below 2.5 in my hands because I like to space them apart and put little injections everywhere, again, to balance and not to paralyze.
Mhm.
But I do know a lot of individuals that use 1 to 1. I've just been using 1 to 2.5 or 1 to 3 for a long time, and I'm comfortable and I also use a 34 gauge 4 millimeter needle in the upper forehead. Uh,
Mhm.
little injections, and certain areas I'm going deeper, certain areas more superficial. So I'm doing different techniques for different parts of the face.
I agree. It's the right tool in the right hands for the right part. Like there's no right or wrong as long as you know what you're doing. I think that's what precedence. I feel in that field, and I see it a lot. People looking for cookie cut approach. Just give me the units, give me the injection points, and that's what I want to use. And I stress it out a lot in our training. There's no such thing. It's different for me, it's different for you. There's no one single face that are like another one. And I feel like there is no cookie cut approach in that field. And you tell me if I'm wrong, but that's the experience that I got in 10 years that I've been doing it. I don't have a map of telling you everybody should be getting this. It's different based on the muscle anatomy. It's different on what results we're looking for, how lax the muscles are, and everything else. So you tell me if I'm off in that respect.
No, you're 100% on target. Everyone has to be appropriately evaluated. Not every procedure is appropriate for every patient.
Mhm.
That's where you have to decide what is best for the patient, which in the end is best for you as well. If you have happy patients that are pleased, they not only will come back to you, but also refer patients and tell their friends how great you are and how things are. That's how you build a practice. If you have a few patients that are very unhappy or disgruntled because you've put too much in or listened to what they want instead of using good medical sense, that's when you have a complication and a problem. I mean, look at Michael Jackson. Whoever did his nose put too many bone grafts in there and eventually fell apart. They interviewed me after that happened. I said, whoever was doing it, I didn't know the doctor, probably shouldn't have done that procedure on him, but they listened to what he wanted as opposed to what was appropriate medicine.
Yes,
We always
exactly.
have to be medical clinicians first.
Mhm.
We have to treat the person from a medical perspective. It is a cosmetic procedure. It's a rejuvenating anti-aging procedures that we now have, but still we are medical professionals, and we should always look at that and not rush through. If you have a med spa and you're seeing 10 or 15 people an hour, you can't do optimal work. You can't. It's impossible. You have to
Yes.
take your time and space your patients out and do the best work for them, which will come back to being rewarding for you as well.
Yes, absolutely. Well, I think a number one question everybody has in our mind, if you do combine procedures, since we still are in the business, we do what's the best for the patient, but we have to look at our bottom line and pay our bills. So is it cost effective for us to do these procedures? And this is just the brief slides that we put together just to show you the profitability of combined procedures. This is just for the treads, and treads are profitable procedures for you as a clinician and seeing good results if they done correctly with the good technique with the right patient. Revenue wise, it is cost effective. We're talking about if it's middle, one third of the face, cost roughly would be 250 to 500 per for the treads themselves. And revenue wise, on average, the cost for a tread lifting, and I recommend usually to charge per area, not per tread. And we had that discussion, Dr. Rosenthal, before.
Yes.
When you telling patients that you're charging them per tread, that's when the hustling and haggling for I need only 3 treads, I want only 4 treads. No, they're not the one who making this decision. Decision is for you to make as a clinician. Whatever it takes to get the results, could be 10 treads, it could be 15 treads, it could be 25 treads. They shouldn't be making that medical decision on your behalf. And I recommend to charge per area. So whatever treads it take, your cost of the procedure should be included in the price that you would be charging that patient. For the forehead, around $200 cost for the treatment. Revenue, it's about 1,500 to 2,000. And if we're talking about neck and under chin reinforcement, then roughly around 2,000, 2,500. Again, the prices dependent on the area you are and what kind of treatments you're combining, but that's an average of the revenue for just the tread lifting procedure alone. If we're combining modalities, this is the prices, and I selected the most common states. They might be different because I see that we have our audience from other states as well. But for tread lifting, full face, 2,000 to 7,000 in New York. You combine, you add Botox injections, around 400 to 800, depending on the amount. Derma fillers, usually 700 to 900 per syringe. That's at least what I've seen in New York. So your combined treatment for that full face rejuvenation could be from 3,500 to 8,000 per treatment modality, right? Together, and it's could be the same day. You could spread them apart depending on what you're doing if you're combining them, but that's a very average based fee structure for state of New York, Illinois, and California. I don't know in Connecticut and after Rosenthal if your pricings are much different, but I think on average that's the price range that we offer. Anything that you could share from your experience?
Well, I agree. Charging by thread is not an optimal way to do it because if the patient says they only want 4 threads and indeed they need 15 or 20 threads, that's not going to satisfy them. The results won't be good. They're going to feel that they wasted the money. You're going to be unsatisfied because the results don't look very good. And so I charge by the areas. When I'm doing threads for the face, it's usually doing the cheek and the mandible at the same time. And then if I need to do the neck, I add that as well. And so it's really by the zones that I'm doing. And same thing with the neurotoxins. I don't charge by units, I charge by the areas. And that way I know I can do the best for them. Fillers are charged by the syringe and also by the complication of what I'm going to do. So I might charge a little bit more for lips if it's going to take me longer. Might charge less for cheeks. I might charge less for the second syringe of a filler on a cheek in order to accommodate the patient and make it more realistic for them. So everything has to do with what you're doing and to evaluate the patient.
Yes, exactly. I agree. So, you as a provider should be guiding how it will be for the patient, the cost, and you have to obviously include the cost of the materials before you set up the prices. I had practitioners that will tell me, I work full day and full months, busy with clients, busy with patients, but then when we look at the bottom line at the end of the month, I barely make any revenue. And then the question comes up, maybe the prices are wrong, or you're not calculating the cost of everything into equation, and maybe something needs to be changed. We did a business class actually last month for my students, so which was eye-opening experience for a lot of them. They didn't even consider the to count the cost of consumables into the cost of the prices that they're putting in for their procedures, which I had the same mistake when I started out, and then I took some business classes and learned, but that's a common mistake. Okay, for we have 73 people actually, Dr. Rosenthal, staying with us. I hope that it was interesting information. We would be answering some questions. I see some questions that are coming in. But before we go into questions, we promised a bonus, and we have a bonus for you guys. We are scheduling, Dr. Rosenthal is actually scheduling a training class with us on November 16, when we will be training on these three different modalities together in New York City. So whoever is interested, you're welcome to join that class. We will be sending information on the class for you. And the present that we're giving you, for those of you who stay with us until the end, you're getting $1,000 voucher for toward that tuition, toward that class, or if any other of our classes. So let us know if you're interested. We will definitely enjoy training you on our premises with Dr. Rosenthal's help. And this is a QR code and a number to redeem the voucher for whoever is interested. You could definitely write it up. And while you're getting all this information, there's more question that came in, Dr. Rosenthal. So let's get to answer some of those questions. They're getting excited to receive answers. And while we're answering the questions, a little bit more information on our academy for different injectable courses that we offer. We do a lot of different courses, and we also offer internship, and that's what Dr. Rosenthal was mentioning. Then a lot of times, if you don't have an experience, coming in for one-day training is enough. It has to be multiple training sessions. So when we set up our training center, I realized that because personally myself, I didn't get enough hands-on when I was training 10 years ago. So we offer it as an opportunity to shadow us, to train and inject on models. We usually schedule models in between our patients when you come and shadow us. So it's a good experience to start your practice when you come in and you see hands-on how the practice is run. We inject multiple patients and kind of give you more experience than you could get in a one-day training when you're starting up. I think it's very important. Let's get to questions. But while we're answering questions, if anybody didn't get a chance yet at the beginning to follow us or get more information, so we have whoever joined us, our attendees, they're from other states, and we have medical providers as well as lay people joining our webinar. So if they are looking to visit you, Dr. Rosenthal, and become your patients to achieve the beautiful results that you showed us, how can they find us? I posted the Instagram, I posted the website, but is there any other magic place that they could find you faster? Tell us a little bit more.
Well, if they look at my website, www.jeffreyrosenthalmd, that I wrote the entire website. They're my photos. It gives you a good understanding. But the office number, and there's always someone, there's a human there during the day, not a machine. At night, there is a machine to leave a message, but that's 203-335-3223. And so they can call up and speak with one of my great managers, and we can arrange. And again, I don't rush. So if you can't get an appointment the next day or in a few days, don't give up, because I won't rush through you, just like I won't rush through anyone else. And I did want to clarify that present. It's not me in the box, right? No, they don't get me. They get $1,000 voucher.
Yes, yes, that's for sure. You're not in the box. Your knowledge and expertise is far beyond $1,000. Trust me, I've seen you in training, so very amazing. Some of the questions. Any preference in toxins? That's what people asking. I could answer it, and then you could add what's better, Botox or Xeomin or Juvo. I have this question being asked constantly. There's no such thing as what's better. Whatever is right for the patient, because I had patients that might be already resistant to Botox, then we switch them to Xeomin. The Xeomin doesn't work, then we could switch them to Juvo. You can't guess it. You don't have a direct answer to that question. At least I don't, but I've seen it. If something doesn't work so for the patient, then I switch it to a different product. And you tell me, Dr. Rosenthal, if you have a different experience, because that was at least my experience in so many years that I've been injecting.
I think most of the neurotoxins that have the same mechanism work the same, and it's just a matter of knowing how to use them and place them. And so I've used Zeman when it came to Connecticut. They asked me to trial it. I've used Botox. I've used Jeuveau. I've used most of them, and I find there's very little difference between them. It has to do with availability of the toxin, and also some of the products continue to increase their fees to us every year. And in doing so, they've sort of priced me out of wanting to use them because I don't want to keep increasing my fee for the patient. And so I found neurotoxins that are very effective, and I'm happy with the ones I use. I have a selection of them.
Yes, me too. I have probably all of them. I recently added Maya Block to my arsenal, and my block is botulinum toxin type B for patients that are getting resistant almost to all of them. Latibo and Maya block are newest on the market, and I feel like people are not resistant to them yet. So that's the one that I added, and I feel like you have to work with different ones based on what your patient needs are. Um,
Let me comment on that. It's interesting about the resistance. They found that if you have a patient that comes back within a very short time of your doing it, not just a minor touch up, but wanting something within a month or two, those individuals do start developing resistant. So resist the temptation to do what they want and make them so they can't move at all, and give them a good 3 to 4 month interval before you do it again.
yes. That's true. I've seen that too. I mean, the more often they do, the more resistance they get usually, and kind of I've seen that a lot too. Treating pricing, that's what kind of comes up a lot too. Pricing, I think you mentioned that you price toxins and threads, and I do the same thing per area, not per unit. When we started our practice, I asked my receptionist, and that could be just a good business advice. I asked my receptionist to do a secret shopper calls to all the facilities in our area that provide similar treatments. And with that, we kind of got an average a ballpark of a price range in our area, and we try to stay within the same range more or less. Why? Because if you're offering much lower cost price than on average your area offers. I had patients or students sharing stories that people will come in is like, why is it so low? So they might question your credibility, they might question the products that are being used. And if you are trying constantly to run a game of price hagging, you will never win. They should be coming to you for expertise and not for the lower price. Those clients, very rare when they stay, they would be hopping from one location to another. In regards to charging more than average what in your area, then you have to really have a proof, or hopefully one day you will get to the point that everybody just comes to you for whatever price you charge. But until you get to that level, my advice would be stay within the range, a little bit more, a little bit less, and take the cost of consumables into the account before you put your prices, especially if you planning to offer any discounts. You cannot offer discounts from the lower price that you have even lower, because you will not be covering even your costs. So it's a bad business model when you do not consider those things when you set up your prices, and it has to be done correctly for you to provide proper treatment, so you're not haggling and struggling on how many units to administer with the patient, plus business wise, so you cover your bottom line and you kind of have some profit and revenue from the treatments that you provide. I don't know if Dr. Rosenthal, you have something else to add to that.
No, that was a very cogent answer, and I agree. You shouldn't haggle with the patient, and you shouldn't be the lowest, shouldn't be the highest. But you also remember, once you become an expert in these fields of endeavor, they're not even paying for the product; they're paying for you to
For
do it.
expertise.
That's the important part. And if you're running an assembly line and you're getting people in and out, and you're not getting great results, then you can't really charge much more than anyone else. But if you're taking the time to carefully evaluate someone, to spend the time explaining it to them, to make sure that they're happy and they've had the best results, then they are willing to pay more money because you're giving them the time and the effort to do it. And so my patients don't come in and say, the ones that know me, what are you going to charge? They trust me. They know I'm not going to overdo something, that I'm going to take their pocketbook into consideration, and I'm going to do the best I can. And that's how we work it.
Yes. Another question is in regards to what fillers do you prefer? I don't think there's a preference. You use the right filler from the right category for the right treatment area, right? Dr. Rosenthal, I don't know if you have any preferred. I use all of them. I use Restylane, I use Juvederm line, I use RHA, whatever. Evolysse recently came on the market, so I started to playing with Evolysse and see what their product line is like. I don't know if you have any preference in the product line for the fillers.
I use, as I said, I use Radius, a lot of that. And then the hyaluronic acids, I use the RHA one, which is from Switzerland, because it has elastic properties. It sort of blends into the skin and moves. Everlist came out. I've been using that as well. And Restylane also has some good products that I selectively use. So those are the three main ones that I'm using, plus Radius, which is not a hyaluronic acid, it's a calcium.
Calcium contracts appetite. Yes, me too. I feel like Evolysse has a texture a little bit similar to RHA. I love RHA product. I use them a lot too. I feel like they're a little bit similar. I don't know if you had the same experience with Evolysse and RHA.
It's supposed to be very similar to RHA4.
Mm-hmm.
So they have the smooth and the form's supposed to be a little less than 4. Although I find that sometimes I get a little better lift, and actually there's a little bit more in each syringe. And
Mm-hmm.
so if you know what you're doing and where you're placing them, then you have to select which product is best for the patient.
Yes.
Around the lip area, I like RHA3 a lot. I've used Kiss. I've used Restylane L, but I do like RHA3 for a moderate lift, not overly big lips. But when I do the lips, I'm not just feeling the mucosal area, I'm actually feeling the lip skin, which is the region from the base of the nose all the way down through the pink part of the lip. That's lip skin. And as women get older, if you're just feeling the lip, you're getting that duck look where it's pushed up because they've lost bone in their maxillary area and volume and fat. And unless you replace some of that with filler and take away some of the lines, then you're going to get a very distorted looking lip. And so, again, the products have to be placed where they're appropriate.
Right. Another question now that you mentioned the lip is if you are performing lip fillers, do you prefer any products, specifically if they're asking if it's a Russian lip technique that they use? Any preference on the lip fillers, Dr. Rosenthal?
Yes, as I said, I like RHA3. I've used Kiss. I've used Restylane L. Those are the ones that I preferentially use on the lips themselves.
Yes, and I feel like it's more a technique that makes a difference, plus what look patient is looking for. Most of my clients, they want more natural looks, so I use softer fillers like Restylane Kiss or RHA 3 or 2. I know there's some groups of patients that would like more firmer look and larger look than there's firmer fillers that could be used. I've seen people use Versa Kiss. I've seen other products. It's all preference on clinicians, I think. Part and the skill that they have. That's basically what my experience was. I think we answered all of the question. It's already 1.5 hours and people are still with us, Dr. Rosenthal. I guess
That's
it
great.
is interesting topic. So thank you everyone for joining us. Any final thoughts, Dr. Rosenthal, that you would like to share with our audience?
No, it was rewarding having this talk with you. It was great. I know we've given a lot of information, and don't try to learn and memorize everything we've talked about. That's the reason why you come to the seminars and the teaching at your facility, to constantly upgrade, learn, and grow, and then to have hands-on experience. Because without the hands-on experience, just listening, it doesn't always, you can't conceptualize it well. And so the combination of information and using the hands and using your eyes and the thinking about it, that'll give you the best results. But it was my pleasure to be with you and to hopefully answer some questions and help your audience. And I
Thank you. Thank you
thank
very
you
much,
all.
Dr.
Thank you all
Rosenthal.
for listening in.
Thank you, thank you. And thank you, Delros, for such a sweet comment. One of our students is writing good comments for us. Thank you, I appreciate it. Good night, everyone. Hopefully, we'll see you in one of our trainings. And whoever is interested to come and join Dr. Rosenthal on his training on November 16, send us a note and hopefully we will see you there. For now, all of our trainings are in New York, unless Dr. Rosenthal, you offer something in Connecticut as a training.
No, I don't do the training actually in Connecticut. I train with you. I'm just doing my private patients or those that wish to become my patient in Connecticut.
Okay, no problem. Thank you very much. Thank you, everyone. Good night.
Good night.